In this presentation, we will be discussing the management of cervical spine fractures. In 2006, there were about 23,000 hospitalizations in the United States due to cervical fractures not involving spinal cord injury, at a cost of around $36,000 per injury, and there were another 4,400 cervical fracture hospitalizations with spinal cord injuries involved, at a cost of around $117,000 per injury. 75% of these admissions were male, and 40% were between the ages of 18 to 44 years old. 80% of patients admitted to the emergency department unconscious due to a motor vehicle accident had a fracture of the dens. The incidence of cervical spine fractures is highest in the 15 to 45-year-old age group and peaks again in the 65 to 80-year-old age group, as there is a high incidence of dens fractures in the elderly population. This table identifies frequent levels of the cervical spine involved in fractures, showing that those fractures which don't involve spinal cord injury occur the most at the level of C2 at just under 40%, and in cervical fractures with spinal cord injury, the most common levels of fracture occur at C5 through C7, accounting for 60% of them. Looking at the healthcare burden of cervical spine fractures, a study by Baj et al. Looked at national hospital databases over a 10-year span in the United States, which showed the cost of hospitalization due to cervical spine fractures rose from about $500 million in 1997 to $1.3 billion in 2006. This is an increase of 160%. Unfortunately, despite this increase in costs, there was a lack of significant improvements in outcomes at the time of discharge. The mechanism of cervical spine fractures include motor vehicle collisions, of which there is a correlation between an increased risk and an increase in speed, rollovers, and head-on collisions. Falls, of which there is a correlation between an increased risk and an increase in height of fall, as well as an increase in age. And axial load mechanisms, of which there is also a risk with certain activities like playing contact sports and diving. When diagnosing cervical spine fractures, patients commonly present with neck pain, limited range of motion, and numbness or tingling. Cervical fractures are confirmed with imaging using X-rays and MRIs. Looking at the classifications of cervical fractures, odontoid fractures are classically divided using Anderson and D'Alonzo system according to the anatomic level of the fracture. Hangman's fractures are classified based on translation and angulation between C2 and C3. Looking at different odontoid fractures specifically, the type 1 fracture involves an oblique fracture through the odontoid process. Type 2 fractures occur at the base of the odontoid where it attaches to the C2, and type 3 fractures occur when the fracture line extends through the body of the C2. Looking at treatment of fractures in the upper cervical spine, those often requiring surgery include type 2 and some type 3 dens fractures, along with type 2 and 3 traumatic spondylolisthesis of the axis. Those which usually don't require surgery include anterior and posterior arch fractures of C1, C1 burst fractures with displacement less than 7 mm, type 1 and some type 3 dens fractures, type 1 traumatic spondylolisthesis of the axis, and C2 Hangman's fractures. Looking at treatment of fractures in the lower cervical spine, those often requiring surgery include unilateral or bilateral facet fracture dislocation, lateral mass separation fractures, comminuted burst fractures of a vertebral body, and teardrop fractures. Those which usually don't require surgery include anterior wedge fractures and some burst fractures. When considering treatment for fractures in the upper and lower cervical spine, surgery may be indicated when the stability of the cervical spine is impaired. External immobilization like braces are often used when surgery is not indicated. The most common used braces for cervical fractures include the halo vest, the Somi brace, and the Philadelphia brace. The halo vest is the most commonly used immobilizer, although it comes with several consequences which we will discuss in just a moment. The Somi brace is adjustable so it can provide flexion, hyperextension, or neutral positioning if the patient needs it. It also has a better comfort level for the patient than the halo vest. The Philadelphia brace is just a basic neck brace, but has been shown to be an appropriate treatment method for dens fractures with low complication rates. Here is a picture of the halo vest. As you can see, it has a halo which is pinned to the patient's head, then stabilizes around the thorax in order to immobilize the cervical spine. This poses several complications for the patient, including pin site infection, osteomyelitis, nerve injury, dural penetration causing CSF leakage, as well as respiratory function limitations. The halo vest is also associated with significant complications, increased morbidity, and lack of union rates in the elderly population. The halo vest has been used for 50 years, and there has been a lot of controversy about the use of this vest due to the high amount of complications associated with it. As of 2010, no randomized controlled trials have been performed on the halo vest. Remember, while RCTs are important for evidence-based practice because they provide reliable evidence for treatment, case studies can provide evidence on safety of the treatment. The studies which have been conducted on the halo vest have shown that the management of upper cervical spine fractures with the halo fixation is safe and effective. Here's a quick description of the 3 most common surgical procedures for C1, C2 fractures. The first approach is the anterior surgical approach, where the surgeon goes through the anterior neck to gain access to the vertebral body of the affected vertebra. As you can imagine, this surgery comes with several risks. However, this approach is able to maintain the rotational motion at the AA joint. Another surgical approach is the posterior transarticular fixation of the C1, C2. This approach is associated with fusion rates ranging from 96 to 100%. However, rotation at the AA joint is substantially reduced. The last surgical approach is another posterior approach described as a C1, C2 pedicle screw fusion. However, this approach reduced rotation of the AA joint as well. In this study by Konizhny, it shows the outcomes for 3 different types of treatment. As you can see, they found that the use of the posterior screw had a better union rate than that of the anterior and conservative treatments. Keep in mind that this was a small case study. Based on a case study by Kim et al., they deduced that anterior screw took 17.6 weeks to heal, and halo vest took 20.2 weeks with a similar fracture of the dens. The Hangman's fractures that were treated with surgery and halo vest took 5 to 6 months for complete union. Keep in mind, like everything else, healing time depends on various factors. This includes those with dens fractures. FABQ, mode of injury, age, and sex all contribute to the healing of each patient. As stated before, this injury is especially harmful to the geriatric population. Konizhny found that those over the age of 60 were 60% more likely to succumb to their injuries when a dens is fractured. Also, healing times with the older populations are elongated at 7 to 8 months post-anterior screw fixation. Middle-aged and pediatric populations have a great healing time at 5 to 6 months and have a great prognosis for returning to their previous level of function. Next, we'll look at the outcomes and treatment of patients with dens fractures. Molinari et al. Found that healing times were not directly influenced by pain levels, function, or satisfaction. They did find that fatalities related to dens fractures dropped in the geriatric population when early mobilization was implemented. Kim et al. Found that healing rates in those under the age of 20 had a 93% healing rate with surgical intervention. We recommend that the clinical predictors described by Blackmore et al. And the clinical characteristics described by Steele et al. In Table 2 be considered by physical therapists with patients who have a history of cervical spine trauma and no fractures evident on adequate initial screening radiographs. Specifically, these factors can help guide the use of repeat radiography, advanced cervical spine diagnostic imaging recommendations, and medical referral prior to implementing physical therapy interventions. So where do we as physical therapists fit into this? As physical therapy comes into the direct access era, we need to be aware of the warning signs of cervical fractures, and particularly those of the dens. We must conduct a Canadian C-spine questionnaire and clear the VBI when we suspect damage. Know when to refer. After a patient has been cleared for physical therapy, we should start with general range of motion exercises, deep neck flexor strengthening, as well as addressing any psychosocial issues which may arise. That concludes this presentation on the management of cervical spine fractures. Here is a list of the references.